I'm Bob Okello. I've been working on home-based care in Gulu and Kasese district. The World Health Organization have clear guidelines about how to implement home-based care for COVID for those who are mild and moderately ill with COVID. These guidelines were adjusted by the Ugandan Ministry of Health, and the policy was rolled out in June 2021. In Gulu and Kasese district, this happened in the context where caring for the sick people within the home is our usual practice. Home-based care for us takes place in a moral space. It creates and sustains social connection between people who are deeply about each other, who deeply care about each other. Global and national ideas about home-based care are different. They are bringing clinical care into the homes, and it does not work well. That is the idea that people are thinking. At times, it feels like an attempt to colonize our ideas of care. While some would argue that this is a good thing, I think we need to be clear about what is imposed and what these impacts might be in terms of both social and economic. As it stands, home-based care for COVID, as implemented, has been flawed, and it only works well for a small number of people.
I have been working in the village in Kasese district on the border of the Democratic Republic of Congo since 2019. During the Ebola outbreaks in the DRC in 2017 to 2020, there was a permanent military base at the edge of our village. So when COVID-19 unfolded, villagers initially perceived the involvement of the military as legitimate. While restrictions lifted in other parts of Uganda, a partial lockdown continues in our village. The military presence is no longer perceived as legitimate. It is creating a lot of difficulties for us, including having to move at night to the military stationed at the DRC border. This can be dangerous, but they have no choice, as it is the only way to access the crops that they are growing on land that they own or rent in the DRC. My people are also having to pay bribes to the Ugandan military as well as the Congolese militia, not only to access our land in the DRC, but also to carry on trading cattle and other items across the border. The impacts on health and health care are also considerable, and our village health team workers feel undermined by the presence of the military. They ask, why are the armed forces so involved in rolling out the COVID vaccines? Why are they not helping us to take responsibility? What is the purpose of this vaccine? With the breakdown in trust, women are less willing to take their children for routine vaccinations. Of all this is happening at a time when there is a regular influx of Congolese refugees, seasonal, but significant flooding and food security. Thank you.
I am Kelmondo Peter, a PDP research officer. I work in the sub-county in Pakwach district, a bordering point between Uganda and the Democratic Republic of Congo. I have been researching on COVID-19 vaccine enforcement among the local people. Official statistics suggest that they have the highest vaccine coverage rate in the whole of Uganda. The military were closely involved in the providing vaccines, and their involvement caused a lot of fear and anxiety among my people. For example, there was a lot of beating and caning of people who refused the vaccine. In some cases, they beat them until they accepted to have it. In other cases, young women were so fearful of how the vaccine might affect their fertility that they pretended to fall in love with army commanders in the hope that they would be able to help them avoid the vaccine. It would have been better if they had talked to people in a soft way. This would have enabled army officers not to be perceived as the enemy of local people. Thank you.
My name is Bono Ozonga, a researcher with PPP. I've been looking at the social impacts of militarized response to COVID-19 among people living in villages and small towns in the Kapashi district on the border of the Democratic Republic of Congo. Whereas Uganda has an ideal public health governance framework running from central government to local governments, the Ugandan army overran and sidelined the decision-making of these structures, with border areas, including mine, receiving heavy deployment. The armed forces were a feared presence, shooting live rounds of ammunition into the famous fish market in the area, so that people were dispersed. The army continued to behave violently throughout the lockdown. For example, the pastor was beaten until he was unconscious, even though he was a few meters away from his home. A Boda rider was also beaten thoroughly, even though he had official approval to travel from the arrested district commissioner, the issuing authority that time. A prominent businessman was severely beaten until he was unconscious for moving at night. A parent was beaten as he sought emergency treatment for his anemic child. Fishermen were also targeted when they came back to landing sites with fish. With no support forthcoming, people had no choice but to break some lockdown restrictions to survive. For example, Boda riders moved at night through bad and unfamiliar routes to evade roadblocks. People at the border used ungazetted border points. Businessmen hid tradable items in food sacks for purposes of evading security checks. Saloon owners locked themselves inside their shop as they served their customers. Bar owners locked themselves in their room while they drank. Fishermen moved at night with their fish, and so forth and so on. Now, my question to the panel is, with the rise of authoritarian governance, I'm keen to learn from colleagues what all this might mean for enabling meaningful community engagement and resilience. Thank you.
I am Mariam Bibimenya Koi from Sierra Leone. I have been working as a field worker with the Pandemic Preparedness Project, PPP, since the time of the COVID-19 outbreak in 2020. My research was undertaken in Shawi Chiefdom, Kailan district. It was one of the first and worst affected communities during the 2014-2015 Ebola outbreak in Sierra Leone, when a nurse infected was brought home for burial. For that reason, it was an interesting place to observe the impact of the COVID-19 pandemic in 2020. Community leaders in Jawi Chiefdom were especially alert to make sure that their people abided by the national and local rules and regulations for control of COVID-19. This included the rapidly revived local bylaws whereby no strangers were allowed into the community. Even village resident people coming in from other towns or communities first had to go to the local village clinic to be screened by the nurses or community health workers. Lockdown was something that affected the people in their communities, especially pregnant and lactating mothers, as It threatened the food supply and caused inadequate food intake. Military forces regularly visited this section of the chiefdom to inspect whether lockdown was being obeyed. They were thinking that failure to obey the rules would result in the same high death toll of their people experienced during the time of Ebola. The impact of lockdowns on food supplies was significant as women experienced difficulties in obtaining food for the house for days on end. Most fed their children with whatever they could find, and some of these foods were unhealthy. For example, sieve rice blended with a pinch of salt and a few drops of palm oil. Some used rice porridge alone. Those who risked evading lockdown went to their farms to dig some bushams, cassava, etc. for family consumption. Others, whose husbands were motorbike taxi riders, were occasionally able to find some basic needs if and when shopkeepers had stock and were willing to sell items on the quiet. This was a famine caused by COVID regulations. Unfortunately, the government realized after a few weeks that it was dangerous and could not be sustained. The biggest problem caused by COVID-19 at the onset was overreaction based on an initial belief that the pandemic would be worse than Ebola. To conclude, Sierra Leone has to develop its own response and not to follow international advice alone. I thank you all.
I'm a research officer working with the Pandemic Preparedness Project. I had carried out participant observation studies. I made general inquiries and observations concerning the ideas of the people on pandemic preparedness for several months before the pandemic of COVID-19 struck. I was then in place to witness how people then cope with this new threat to their health, livelihoods, and the ways in which their responses changed, both in the face of the epidemic itself when the pandemic arrived in April 2020. One of the topics I studied before COVID-19 arrived was the way in which the chiefdom authorities mobilized the community to resist Ebola virus disease in 2014-2015. This was by means of a chiefdom Ebola task force committee, which imposed nationally mandated bylaws on Ebola control. As a result of strict restriction on local movement, the chiefdom maintained a zero case rate for Ebola infection throughout the 2014-15 outbreak. However, the outbreak of COVID-19 in 2020 changed our research focus from preparedness to response. Initially, there was a widespread understanding that the Ebola response, based on bylaws and quarantine, will also protect against COVID-19. Market and place of work were closed, and social distancing and mask wearing were imposed. Unlike Ebola, the symptoms of COVID-19 were much harder to detect and less dramatic. It was a disease affecting mainly old people, and I undertook household censuses, showing that the elderly were only a small proportion of the total population. Also, the disease spread in a different way on the air and not through contact with body fluid, so was much harder to control than Ebola. There were two problems. Therefore, people could not see the disease, and the benefits of strictly imposed quarantine were much less obvious, since there were very few, if any, serious cases. I also followed up on various other topics. One was the impact of market lockdowns, which were very severe and responsible for food insecurity. Another was mask wearing, which people saw as being beneficial in protecting others, themselves, and bike riders against dust. Later, vaccine arrived, and I spent time following up with informants their changing ideas about vaccines. Initial resistance was linked to misinformation. I followed one chief who had earlier told me he would never take the vaccine. Later, I found that he had changed his mind. He explained that bylaws were the best protection from disease, as under Ebola, but that if he did not take the vaccine, others will not accept the bylaws. In conclusion, pandemics are moving events, and participant observation is needed to monitor often rapidly changing attitudes, understandings, and response. I thank you all.